everyone.
Good morning.
My name is Ronald Rivera. I'm a PGY2, and this is my small talk on hematology. I want to thank Drs. Regan, Dr. Berkenpol, and Dr. Gernsheimer for your help in putting the presentation together. And I guess the best way to start is with a case scenario. So you end up with a 54-year-old gentleman from Haiti who comes into the emergency room complaining of total body weakness. Every time he stands up, he gets dizzy, he feels like he's going to fall down, and he can't even walk at this point because he's so weak and tired and dizzy. You examine his eyes and they look like this. Wait, where'd that thing? Oh, his eyes are gone. You examine his mouth, it looks like this. And you examine his hands and they look like this. What do you think is going on with this poor gentleman? I know, I don't know what happened to his eyes. They got deleted. I don't know what happened. His eyes are very pale conjunctiva. He's anemic, exactly. Okay, so my presentation today is on undifferentiated anemia, what you can do from the emergency room to help work up the undifferentiated anemia. This is not like the anemia, okay, anyway. We'll go on to that. So, we're all familiar with the CBC as the primary test that we do to evaluate anemia. We always look at the hemoglobin and the hematocrit and we decide what's going on with we decide whether the patient's anemic by looking at the hemoglobin and hematocrit. But I'm hoping by the end of the day today, you guys can look at other values that come in the CBC like the MCV and the RDW, but also look at other adjunctive tests that you can do alongside these to determine what the cause of the anemia is. Specifically, reticulocyte counts, Coombs tests, iron studies, and a peripheral smear. So, I like to kill the punchline of the joke. I'm going to give you the main take-home points from my lecture right now so that you can pay attention to where they pop up in the lecture and you can shut off your brains from this point forward, okay? The first thing is, after you get an H&H, you want to start by looking at the MCV and the RDW on CBC. You should always order reticulocyte count if you're suspecting anemia in a patient because this will help to differentiate a consumptive process, or a production process versus a destructive process. If you're sending iron studies for hematology, the iron studies they like most are the double T's, I call them, TIBC and transferrin. And whenever you have a patient with a high reticulocyte count, you should always send to the Coombs. Okay, so let's talk about the four main causes of anemia. The first main cause of anemia is simple, blood loss. Hemorrhage, GI bleeds, gynecologic bleeds, etc. This is loss of the blood from the body. Second major cause is red blood cell destruction. Third cause, and I apologize to you younger interns, you may not understand this reference. This is a problem with production or construction of red blood cells. And then this is an idiopathic cause of anemia, which is hyperdilution. This is when we're resuscitating a patient and we use a lot of fluids and we dilute them to the point where they become anemic. So, knowing that there are these four causes of anemia, where do we start? And like I said in the beginning of the lecture, the things you have to remember, start with the MCV. MCV is the mean corpuscular volume of the red blood cell, meaning it's what is the average size of the cells that they have that are inside your red blood cell count. So, microcytic anemia, it's broken into three categories, microcytic, normocytic, and macrocytic. Microcytic is small. I like to think of this as a tiny boat floating around inside your red blood cells. So, I'm doing this in kind of a like microbiology made ridiculously simple style, so just think about the pictures and try to put the picture combinations together to help you remember what I'm talking about. So, microcytic anemia is a small boat floating around inside your bloodstream. Normocytic anemia is the normal sized boat that you want to have floating around. I would like a boat this size for myself. And that's the normal sized boat floating around in your bloodstream. And a macrocytic anemia you think of as this gigantic boat floating around in your bloodstream, way too big, not what you're normally used to. Okay, so we've looked at our MCV, we've gotten our microcytic, our normocytic, and our macrocytic. What's the next step? If you remember back to the beginning of the lecture, I said look at the RDW next. So, you look at the RDW, which is the red blood cell distribution width. This is a measure of how variable are the sizes. So let's say you have a normocytic anemia, but how variable are the sizes within that normocytic anemia of the red blood cells? I tend to think of this in two different ways. One is a normocytic this is a normal RDW, where all the red blood cells essentially look about the same size, they look about the same, there's not a lot of variability between those red blood cells. The second thing is when you have a high red blood cell distribution width, and I like to think of it as looking like this. They're all red blood cells, but they're all kind of different sizes, they look a little bit different than each other, so you get a high RDW. So, if we combine these things together, looking at the H&H, looking at the MCV and the RDW, we can start with microcytic anemia. First thing, microcytic anemia, small boat. Remember the small boat? So, you have a microcytic anemia with a normal red blood cell distribution width. In this situation, you have to look at one other indice on your CBC, which is the red blood cell count. And you have two scenarios. You can have a microcytic anemia with a low red blood cell count, few red blood cells. You can have enormous microcytic anemia with a normal red blood cell count. In the case of a low red blood cell count, you have to think of anemia of chronic disease, you have to think of hypothyroidism, and you have to think of vitamin C deficiencies. In the situation where you have a microcytic anemia with a normal or a high red blood cell count, then you think about all of the hemoglobinopathies like alpha thalassemia, beta thalassemia. And this makes sense to us because if you're making red blood cells with irregular or small hemoglobin chains, then you end up with small red blood cells, but they're all about the same size because they're all being made in the same way. Make sense? Good. Okay, you're all still with me. The next scenario for microcytic anemias that you have is the microcytic anemia with a high red blood cell distribution way. In a high red blood cell distribution, you got your small boat, but varying sizes of small boats within that within the small boat pool. So in this situation, you always want to grab a ferritin. The reason you grab a ferritin is because there's two scenarios within the ferritin that can help you determine what's going on. First, you can have a microcytic anemia with a low concentration of ferritin with high red blood cell distribution with. Low, it's lighter in color, it's low concentration. And then you can have the microcytic anemia with a high red blood cell distribution with that's higher in concentration of ferritin. In the first scenario, you have to think about iron deficiency anemias, which makes sense to us because if you don't have enough iron, you don't have ferritin, which is the protein that holds the iron within the cells of the body. So you don't have a lot of iron, you don't have a lot of protein holding the iron. In the second scenario, you have to think about anemia of chronic disease and sideroblastic anemias. And this makes sense because this is a problem with getting iron out of the cells, right? In a chronic disease state, the iron is being sequestered inside the cells, and in sideroblastic anemia, the iron can't be used properly and it's stuck in the mitochondria of the red blood cells, creating these sideroblastic red blood cells on the smear. Okay, so in summary, microcytic anemias, got to look at the red blood cell count. You should order ferritin and iron studies if you suspect iron deficiency anemia. And this is essentially microcytic anemias I would describe as problems with how red blood cells are being made, the construction of red blood cells. So the next anemia we're going to look at is the normocytic anemias. And in the normocytic anemias, microcytic is considered your MCV less than 80. Normocytic anemias are MCV 80 to 100. In this case, we talk about the boat size that we want, the normal size boat. And you start with, you can look and see if you have a normocytic anemia with a high red blood cell distribution with, there's a couple things to think of. First one, iron deficiency anemia. Second one, folic acid deficiency, folate deficiency, or vitamin B12 deficiency. You guys may start to see a pattern here that the ones where you have a high red blood cell distribution with tend to be a deficiency of some vitamin or mineral, so keep that in mind. Okay, the second one is where you have a normocytic anemia with a normal RDW. This almost sounds like it would be normal, but the patient is still anemic. Why? Well, you have to look at the reticulocyte count in this case, and for the purposes of my presentation, a normal reticulocyte count is 1. So, look at the reticulocyte count. You have, if a normal reticulocyte count, you have to think about anemia of chronic disease, and you have to think of anemia of renal disease. So these are two causes of a normocytic, normal RDW, normal reticulocyte count anemia. The other situation is a little bit more interesting. Let's say you have a normocytic anemia, but you have high reticulocyte counts. In this case, defined as 3. High reticulocyte count, you have to send a Coombs test. You either get a positive Coombs or a negative Coombs. And in this case, if you've got a normocytic anemia with a high reticulocyte count and a positive Coombs, you got to think of autoimmune hemolytic anemias. Sorry, this presentation has a lot of dad joke-worthy puns in it. I apologize now for that. Just trying to help you remember with humor. In the second situation, you have a normocytic anemia with a high reticulocyte count and a negative Coombs. And then you have to think about enzymopathies like G6PD. You have to think about hemoglobinopathies such as sickle cell anemia. You have to think about membranopathies such as hereditary spherocytosis. And you should also think about microangiopathic hemolytic anemia. Other things you can look at to help you determine whether to differentiate between these 4 pieces is you can look at adjunctive studies like your total bilirubin, you can look at your lactate dehydrogenase, and you can look at haptoglobin to determine if this is a consumptive anemia or angiopathic anemia. So, summary of normocytic anemias. Look at the reticulocyte count. If you have high retics, order a Coombs test. You can use your bilirubin, your lactate dehydrogenase, and your haptoglobin for suspected hemolysis. Does anyone remember what your haptoglobin will be, high or low in hemolysis? Low, yay, you're all clinical monsters, I love you. And on Valentine's Day, I love you more. So, summary is, normocytic anemias are generally a mix of problems with production and problems with destruction of red blood cells. So, can you guess where we're going to go to next? Macrocytic anemias, okay, excellent. So, remember the gigantic boat that we have here, too big. So, in this situation, you have a macrocytic anemia with the normal red blood cell distribution way. So in this case, you're going to think about alcoholic anemias. You're going to think about anemia of liver disease. And you're going to think about hypothyroidism. And then you're going to think about myelodysplastic syndromes. And in this situation, you really have to start looking at some of the other indices that come with your CBC. You're going to look at your white blood cell count, you're going to look at your platelets, and you're going to see if there's high proliferations of any of those lines, or you're going to see if all the other lines are suppressed, because that may give you an idea of something like a hematologic malignancy that might be going on. The next scenario is a macrocytic anemia with a high red blood cell distribution width. And remember, in the beginning I said that there was some sort of connection to high RDW. You remember what usually causes a high RDW? Deficiencies, right. So in this case, you've got folic acid deficiency, B12 deficiency as your causes of it. An important thing to note is that if your MCV, which macrocytic is considered greater than 100, generally if your MCV is 115 or higher, it's almost always indicative of a vitamin B12 or a folic acid deficiency. So in summary, macrocytic anemias, extreme macrocytosis is almost always B12 and folate, and look at the other cell lines to determine whether there's some myelodysplastic process at play. Macrocytic anemias, in general, are a problem with production of red blood cells. Okay, so I spoke with the hematology residents and asked them if they had any pitfalls and pearls they wanted to give us as ER residents of things that we should always do or should not ever do, and here's what they came up with. When you're looking at anemic patients, they want you to look at what's called the gamma gap. This is the difference between the serum protein and the serum albumin. And if the difference between serum protein and serum albumin is 5 or greater, you should suspect multiple myeloma. So they want you to get an SPEP and free light chains to work up for multiple myeloma. Okay, another dad joke. If you're suspecting a hemolytic process, you should get your dehydrated lactate, powdered milk, dehydrated lactate. Okay? Lactate dehydrogenase and haptoglobin to evaluate for hemolytic processes. If you suspect DIC, you should always send a fibrinogen, as a way to look for evidence of DIC. I told you, dad joke level jokes in here, okay? All right. The other thing was they want you to pay attention to all the cell lines when you're looking at your CBC just to make sure that there's not proliferation of one particular line or depression of all the lines, which may give you an idea of an aplastic anemia versus a myelodysplastic anemia. And I don't know if you've noticed, some of the seniors you probably noticed, but when you do a CBC, you get initial results back, and if you check back a little bit later on in the evening or in the day, there's usually a portion at the bottom in quadrant that's the results of the smear. If there are too many abnormal values, they'll do a manual smear and look at it under the microscope. The recommendation is if you see in the results of that smear that there's a lot of nucleated red blood cells or spherocytes or other crazy morphologies, that's pretty much a good indication for a hematology consult at that time, because they'll look at the smear and they'll be able to help you figure out what's going on. The final piece of advice that they gave was about transfusions. They generally recommend transfusing patients under a hemoglobin of 7. They recommend transfusing patients who are symptomatic or show signs of end organ dysfunction due to their anemia. But the other thing to remember is during ACS, you want to try to keep someone's hemoglobin above 8 is what their recommendation was. One other caveat with transfusions is that if you transfuse the patient before you send all of your studies, you're going to ruin the indices of the study, and they won't be able to use these fancy fun pictures to figure out exactly what's going on with what's causing the anemia. So if you can draw the blood before the transfusion and send off the studies you plan to help figure out what's going on. So, in summary, order a CBC and look at the H&H. If the patient is anemic, look at the MCV, the RDW, and the reticulocytes. Determine if this is a microcytic anemia, which is typically a problem of the construction of the red blood cells, like the thalassemia, like thalassemias, or if this is a normocytic anemia, which is either a problem with production or destruction, or if this is a macrocytic anemia, which is almost always a problem of production of red blood cells. If the RDW is high, it's typically some sort of deficiency, like we said. So check the levels of folate, B12, and consult hematology if you encounter any weirdness that you're not able to explain otherwise. Questions?
Very good.